Stephanie Price, and in this discussion, we'll talk about men with an elevated prostate-specific antigen, also known as PSA. This presentation aims to provide evidence-based information about men who are considering PSA screening for those who have been screened previously and have an elevated PSA, and for nurses and caregivers of this particular population. In defining this population, we will look at men and persons born male with an elevated PSA. The PSA is a common used lab test to detect prostate cancer. Fortunately, this is a very simple blood test that can be done in office with same-day results, though PSA levels may be elevated for both benign and malignant reasons. The issue of concern is that patients should be informed about the positive and negative aspects of PSA screening, including benign increases in PSA and what are the reasons for those. And some of those can be prostate infection, trauma, riding, maybe horseback, lawnmower, bicycle, those type of things, anything that kind of rubs along the prostate, and also recent ejaculation. These things can increase the PSA, subsequently leading to an overdiagnosis of prostate cancer. Prostate cancer is the most common cancer among men as far as non-cutaneous cancers are concerned, and early detection does allow for a 5-year survival rate greater than 90%. Now, the American Cancer Society does recommend prostate screening to begin around age 50 and at 45 years for those of higher risk. In the community where I did my practicum, which was in Etowah County, Alabama, you will see by looking at this table that the rates of prostate cancer in the community are significantly lower than those in the state of Alabama and also in the United States. There are a few things that do need to be considered when we look at prostate cancer screening. Again, that prostate cancer is the most frequently diagnosed cancer, excluding skin cancer. However, most prostate cancers are very slow growing and may never become clinically significant. And a lot of men actually die from other conditions before their cancer does become clinically significant. Therefore, routine PSA screening can be somewhat controversial. Another thing that we really need to keep in mind when we're talking about and considering PSA screening is that transgender women do have significantly lower odds of having that recent PSA screen compared to others. And some of these disparities may be associated with the clinician patterns of care rather than differences, in sociodemographic characteristics or access to care within that community. The current evidence available does let us know that the PSA screen is highly sensitive, but it is poorly specific for prostate cancer detection. Typically, men will come in to be screened for one of two reasons, and that's either that they're having some type of lower urinary tract symptoms, or they're asymptomatic, but they are concerned about their own personal risk of prostate cancer. In prostate cancer, that PSA level elevation is the most common initial finding. Patients are generally asymptomatic in early prostate cancers. And again, the PSA screen is highly sensitive, but non-specific. So both benign and malignant conditions can elevate the serum marker. This can lead to risk of overdiagnosis. And here again, that is actually diagnosing prostate cancer at a point when it is clinically insignificant and may never have any type of negative impact on the patient's life or overall outcome. Screening one of the big things that it should do is to incorporate the benefit, the cost effectiveness, and the quality of life. And even at a point when we look at our patients and we see that they only have about a 10-year or less life expectancy, that may be a good time to discontinue PSA screenings. When we look at the needs of this population, it really comes down to men needing to receive age and risk appropriate PSA screening. Because it looks as if as many as 44% of men actually have a very limited awareness of prostate cancer and PSA screening. And another thing is that early detection can increase that life expectancy because we have diagnosed these significant prostate cancers at an early but curative state in the disease process. Let's have a real quick look over the Clinical Urology Associates Clinic where I actually did my practicum and project implementation, where some of the strengths, weaknesses, threats, and opportunities are listed here. Some of the ones that I actually want to bring to your attention that I felt like were excellent strengths were several physicians and nurse practitioners on staff, as well as that on-site lab that was able to give patients same-day results as far as their PSA level was concerned. Also, they do participate in Man Up Gadsden, which is a nonprofit organization focused on men's health, testicular cancer, and prostate cancer awareness. Now, some of the weakness that I noticed, really the most significant, was that they do not allow walk-in patients. And other threats were very heavy patient load and a very, very heavy consult and referral load. Fortunately, the community, as you look here over my windshield survey, fortunately, there were 2 hospitals in the community. The community is well maintained. It seems to be very safe and well lit at night. Also with public transportation to kind of help those patients get from point A to point B in a safe and also cost-efficient way. As I continued to assess the needs of this population, I spoke with a physician in the clinic, a nurse practitioner, and also a community member. The clinician felt like some barriers really included fear or embarrassment, specifically related to digital rectal exam, where the nurse practitioner felt like non-compliance was a big issue, but very significantly, the community member denied knowing about any community resources for PSA screening. During my project planning and project implementation, I did use Nola Pender's health promotion model to encourage patients to participate in community-based programs. And patients are more apt to participate in community programs whenever there is a perceived benefit. And when they see the benefit of cancer prevention and early detection, those levels of participation may increase. Here we look at some both modifiable and non-modifiable risk factors for the development of prostate cancer, including carcinogen exposure, race, of course, male gender, any history of malignancies, other exposures, occupational exposures, cadmium and Agent Orange exposure, often seen in veterans. Here we look at primary, secondary, and tertiary prevention. Primary, of course, we know is our most cost-effective means of prevention. And here again, that's that avoiding those carcinogens and creating that more healthy lifestyle. As to where secondary prevention would include the early detection of prostate cancer through PSA screening, and tertiary prevention includes slowing the progression of the cancer, treating the disease, and improving that overall quality of life. Here we look at the project plan for both patients and their families, as well as the community outreach portion where signage was placed throughout the community and in various places of employment. As we look over the community diagnosis, we do see again that I mentioned before, the priority community diagnosis is lack of awareness regarding available resources for PSA screening here in the community. On this slide, we look over the 5 roles of the APHN in promoting Healthy People 2030 goals, and also the intervention of focus, which is to increase awareness and increase rates of PSA screening in males over the age of 50. This slide describes the 3 objectives, one for the patient, one for the family member, and one for the community. The patient will describe the importance of PSA screening in prostate cancer prevention. Family members will demonstrate involvement, and community members will use the educational material that I provided during my practicum and project implementation regarding decision making for their own PSA screening and prostate cancer prevention efforts. And now we take a quick look at the resources needed, including resources to make the pamphlets, as well as the signage, the budget, and the timeline for both community, as well as patient and family education. Barriers include unwillingness to participate, time constraints in the clinic, availability of private rooms for education, and most commonly is the absence of family members during the visit. Challenges include permission to display signage and posters, the financial burdens of supplies, and the potential for removal or destruction of the posters. During my project implementation in the clinic, family and patients were provided with educational pamphlets and verbal educational material that they were able to look back on throughout the discussion. Each meeting was held at the end of the office visit for approximately 10 minutes each. Again, the pamphlet served as a visual guide, and patients were able to recall greater than 75% of the material provided during the educational session. For the community portion of the project implementation, educational posters are placed in men's rooms throughout the community. These are placed over the urinal at eye level so that men could see these and discuss the information they collected from the posters with other men and spread the information by word of mouth. During the patient's verbal recall of the information provided, they were able to restate the importance of PSA screening, community resources for screening, and the risk and benefits of screening. Barriers and challenges included some budgeting issues that I ran into, time constraints. Oftentimes, family and caregivers were not present for teaching and education. And the big thing for me was the inability to let patients know ahead of their appointment that there would be education at the end of the visit, as well as a very low number of patients who were actually in the clinic for PSA screening. Overall, the project was successful and sustainable with very few barriers and challenges faced, and the information was provided in an understandable way that was visually appealing to patients as well as family members. Improved knowledge for community resources was evidenced by greater than 75% recall of the education provided, which has the potential for reducing metastasis at the time of new diagnosis, and also the potential to reduce mortality rates from prostate cancer within the community. My recommendations for the future would include providing patients in the clinic beyond the practicum with the written material regarding PSA screening, as well as literature about the Man Up Gadsden initiative, and also using zerocancer.org as a resource for patients with a new or suspected prostate cancer. I would also suggest teach in larger groups as opposed to individual education, and having a little bit more widely defined population of interest so that you're not incredibly restricted to such a very small group. And in conclusion, this project and implementation has allowed the number of men in the community with sufficient knowledge regarding PSA screening to increase, and thus has the potential to continue increasing as resources continue to be shared in the community and beyond. I just want to take a moment to thank you so much for spending the time to listen to this education, and also welcome you to pause on this screen to review any resources that you might find useful in the future. Thank you so much.